Hello, everyone, and welcome back to another webinar of the Direct Specialty Care Alliance. This webinar is about direct care, and today I have the pleasure and the honor to have another amazing guest, Dr. Lucia Cheng. Dr. Lucia Cheng is a board-certified psychiatrist who is specialized in reproductive and perinatal psychiatry. Dr. Chen is also board certified in lifestyle medicine. She attended medical school at Medical College of Wisconsin, and she completed a psychiatry residency at Loma Linda University Medical Center. She's currently an adjunct professor at Loma Linda Psychiatry Residency, and she enjoys teaching residents there. While Dr. Chen is based in California, she does see patients across the United States. She has a telepsychiatry private practice that is called Phoenix Progressive Psychiatry Services. She volunteers as a perinatal psychiatry consultant for the Postpartum Support International Prescribe and Consult line. I'm sorry, this is the first time when I hear about this. And she also currently serves on the board of directors of International Society of Reproductive Psychiatry. And very, very interesting, Dr. Chen is an avid video gamer, specializing also in providing mental health care to other video gamers. Dr. Chen, welcome. It's a pleasure to have you here.
It's a pleasure to be here. Thank you for having me.
So today we're going to talk about direct care, and as I ask the other guests of my webinars, tell us your story about how you landed into direct care.
So the basic gist of it is I burnt out. Coming out of residency, I worked for the VA for a short while. I worked for Loma Linda as a professor for a brief period of time. And then from that, I transitioned into a inpatient hospital care setting and then started doing locums. I got my first exposure to telemedicine actually when I was with the VA, because this was over a decade ago. The VA actually got started in telehealth very early on. And, I've been a video gamer for more than half my life. And so sitting in front of a computer was, second nature to me. I loved it. And, I discovered, oh my gosh, I need to make a career out of this. So I decided very early on that telepsychiatry was the way I wanted to go. But I really didn't have a good idea of how to make that possible. And so part of my journey of discovery was, I started getting exposed to locums jobs that were starting to do more telemedicine. And that's how I ended up picking up several state licenses to start. And throughout that progress of doing locums, I started learning the logistics of how to have a multi-state telehealth practice. My very first telepsychiatry locums job actually had me credential in 3 different states, and I was seeing patients from a different state each day of the week. So it was very exciting. I loved it, but I struggled with dealing with admin. I'm very opinionated, and I hold very high standards for myself to how I treat my patients, and the admin interference with how I felt like I should be practicing and how I wanted to be treating my patients, it just wasn't compatible anymore. And I became progressively more and more burnt out. And it got to the point where I actually was severely depressed. So I decided I had to make a change. I wasn't sure if I even wanted to stay in medicine because, it was like, if this is medicine, I'm miserable. I can't do this long term. So I made a decision. I quit my job and I packed my bags and left the country for kind of like a 3-week trip to find myself. I went to Cardiff, Wales. Fantastic, life-changing trip. When I was there, I tried my best to not think about work. I was just there, chatting people up, taking hikes, looking through old castles. And what I found that I enjoy the most was actually talking to people. Every time I, walked into like a Castle Books gift shop, I would be chatting up the shop owners. I really enjoyed sitting in coffee shops and just chatting with whoever happened to be there and sat down with me. And then I realized at the end of those 3 weeks away, I really loved hearing people's stories, which is the essential of psychiatry. And I realized I really love being a doctor. I really wanted to practice psychiatry. I just had to practice it my way. And that was when I decided I have to go into private practice because I need to be the one to be able to control how I practice. And that's what got me started in my own specialty practice.
Thank you for sharing the story with us. When did you start your practice?
So it took a little bit of time for me to start learning more of the medical legal logistics, because there's a lot of laws and other things, tax laws, medical laws, prescribing laws, etc., that I really had to figure out. And I wasn't quite ready to start when I came back from that trip, but I started planning for it. By early 2018, I felt ready. And that was when I started Phoenix Progressive Psychiatric Services. And I jumped in full bore. I quit my job that I had at the time and said, I'm just diving right in, and went into full time. And fortunately for me, it worked out quite well. And honestly, I've never been happier.
That's a great story. And when you started your practice, did you start in direct care or did you start a hybrid practice?
Direct care. One of the things that I needed to figure out before starting my practice was those little details. Is this going to be multi-state? What am I going to do about controlled medications? Am I taking cash pay only, or am I taking insurance, Medicare, Medicaid, all that stuff? And I was trying to figure out how to avoid burnout for myself, because if I was going to dedicate my time and efforts and energy to my private practice, it needed to be something I could sustain. And I knew that if I had to deal with insurance, it would drive me completely insane eventually. And so I decided very early on, no insurance, private pay only, no controlled medications. So I do not prescribe any controlled, which, with the in-person requirement, I know those got lifted for COVID, but when you're in 11 different states, it's not feasible to be seeing patients in person.
Yes. And when you started, what was the biggest challenge that you had?
Fear. It's terrifying. Ever since I started training, you got used to that monthly paycheck. You had the benefits, you had the paycheck, you had the security. By then, I was the main breadwinner for the family. It was absolutely terrible. We had a mortgage. I had a child. So it was absolutely terrifying. And I kind of had to really work past that. And that was part of that preparation process I went through. I really focused on building a financial, chest savings to be able to allow myself some time to build up the practice. Because I was very aware that when you do a cash pay practice, it grows slowly. And so I needed to be able to buffer myself.
So if you think back, how long did it took you to have a viable practice, to be able to have some cash coming back to you, not to the business?
So about 1.5 to 2 years. I would say 2 years to become as busy as I wanted to be. Mm-hmm. And it's not just sitting there twiddling your thumbs waiting for patients to come in. It was a lot of footwork. Networking, I put a lot of time and effort into networking. Pre-COVID, I was traveling to medical conferences almost every single month. And when I was there, I was ready to talk to people. I was giving people my brochures from my practice, my business cards. I don't do paper anymore. I've gone digital. I actually travel with my cell phone with a QR code from my my practice website that I could just flash at people, and it makes things a lot easier. And then when COVID hit, you can't, all the medical conferences got canceled. And so I actually pivoted and started become very, very active online, specifically on Facebook. I think I'm a member of almost 50 different professional Facebook groups. And I'm not posting all the time, But what happens is I do notice a lot of people ask questions about reproductive psych, or questions about, medications and pregnancy, or questions about what to do about their video gaming, kid. And so when I feel like I have something to contribute, I would jump in and I would, put in my post, and I write my post with the intent to educate. And
Good.
so after a while, I think I started developing a reputation on some of the Facebook groups as being, the person to ask questions about with perinatal psych. I've even had a few people comment that they read my posts and consider it CME sometimes. And, once you develop that reputation, you develop name familiarity with your colleagues, and, not just physicians, but also therapists. I'm in a lot of just therapist groups, because therapists are frontline mental health professionals, and they can't prescribe in most states. And a lot of times, they have trouble finding a good psychiatrist for their clients, and to be the person out there going, hey, I'm available and I know what I'm talking about, I'm legit, they're going to start keeping you in mind when their clients need a prescriber. And that's really how I started growing my practice. It was building that referral network gradually over time. And I have spent in my practice very, very little money on marketing. I think I for a few months starting off, I did spend about $300 a month in my monthly budget for Google ads and Facebook ads. And I didn't find that I got a good return on investment for those. And I realized at the time that to get the quality and the kind of patients that are appropriate for my practice, it really has to be from referrals, because from the referrals, people know who you are, they know what your practice is about, and they will pick the right patients to refer for you. So after the first few months, I just stopped all the advertising, spent $0 on any of that for several years now. And I now have a good, solid, steady referral basis. So I stay as busy as I want to be.
Actually, this is a question that we always get people asking: how do you market yourself? And you already answered the question, but people are using Instagram, are using Facebook, are using YouTube. Do you think you should be on all the platforms, or do you think you should be on one? What is your advice about that?
So, and don't generalize my advice, because this is specifically just for me. One of the things that I learned throughout this process is I learned a lot about myself, where my strong points are, what my limitations are, what I can handle, what I can't handle, what I like, what I don't like. And I realized fairly early on, all these social media platforms, they're valid. They work well. They have, each have pros and cons. But I felt personally that things like Twitter and Instagram and TikTok, it for me, it was just so overwhelming. It was like drinking from a fire hose. And so I felt I needed to pick just one platform that I could focus my time and attention on and do it really well. I'm a extreme introvert. I honestly, it gives me anxiety to be recorded. And so every time I go on these talks and I know that I'm getting recorded, I kind of have to fight that level of anxiety down. So there's just no way that I'm going to make TikTok videos or, I don't have a YouTube channel or anything like that. Because I realized that being responsible for keeping up with making video content, that's just not something that is compatible with my personality. And so you have to understand yourself. You have to understand what you cannot handle. Do not take on too much to where you burn yourself out. Do the stuff that you feel like you can really do well and just really focus in on it.
Good. And let's talk about pricing. This is another question that many of the members that are in the Facebook group, the Direct Specialty Care Alliance also, they have this big question. How do I know that my price is competitive? How do I know that the price that I put there on the website is something that the patient will understand as a valuable resource for them? And that is a question that we get all the time. How did you price yourself, and what did you consider to do that?
Pricing, I feel, it's a very personal decision. You do your due diligence, you look at comps, You think about what areas that you're going to practice in, and you check to see what other psychiatrists are in that area and in that patient population group. Child adolescent psychiatrists are not going to charge the same as general adult psychiatrists because CAPs are very rare, and they deserve more because they've had a lot more specialized training. One of the decisions I had to make, because I was a multi-state practice, is, am I going to charge different rates for different states, or was I going to charge the same rate? And I ended up deciding to charge the same rate across the board because, one, I think I'm not good at doing financial balance sheets. I'm terrible at that. No accounting skills. And I realized that I would drive myself a bit batty if I had to keep tracking which patient was in which state was in what fee I was charging them. It was just not worth the energy and the mental effort that I had to do that. And it was just easier for me to just have one price across the board. The other thing that I consider was, I'm very niche in my practice. While I do see general psychiatry patients, my preferred populations are perinatal and video gamers. Those are not really the affluent populations out there. And also, if you look at the states that I are licensed in, many of those states, I specifically wanted to get a license in because there were not that many perinatal psychiatrists available in that state. And I wanted to make sure that I kept my rates as reasonable as possible so that the patients there could access it. Because most perinatal psychiatrists, they're either academically affiliated, and so you have to be a patient of whatever hospital program they're in, or they're in private practice, cash pay, not taking insurance. And that makes it very difficult for patients. And so I kind of had to do a little bit of soul searching and decide, okay, what price do I charge where I feel like I am being adequately compensated for the time and effort I'm putting in, but keeping it reasonable so that, if people were able to just kind of save for, a few months or a few weeks, they would be able to at least pay for one consultation with me. And that's how I landed with the fees that I decided to charge. I also decided to be very transparent about it. I don't do sliding scale because I feel that I am already charging what at a minimum I'm willing to accept for my time, and I don't charge more than that. So I don't do sliding scale. And since I don't have to bother with insurance and copays and all that stuff, I just decided to put my fees on my website so that it's full transparency. Anybody who even takes a few minutes to read my website will have all the information that they need about my practice that they need.
And as I understand, you are licensed in 11 states.
Yes, and currently. That changes.
You chose those states based on the research that you made, that there are fewer options for patients. How do you market your practice in those states? It's only based on the referrals. You said that you are in those groups and patients will be referred by other colleagues of us, or do you do anything to market the practice in any of these states?
So, like I said, I spend my efforts on Facebook, and I am part of many, many, many different groups. So I am constantly kind of on the prowl looking for posts going in search of a perinatal prescriber psychiatrist for this patient in the state. And when I see that, I have like a little templated phrase that I use that tells about who I am, how quickly I could get patients in, what state I'm licensed in, and my website link. And I copy and paste that in as a comment. And usually, very often, I'm the first one to make a comment there. And so just from that, and, in states like Missouri or Alaska, there really aren't that many perinatal psychiatrists. And so a lot of times I'm also the only person to offer an option. And so that's how you kind of build the practice there, because there are people who, when they are looking for your services, you let them know through when they're looking for it, and you be responsive. You start getting referrals.
Is it common for psychiatry to be cash pay? When you start, did you know anybody else doing direct care in psychiatry?
It is extremely common in psychiatry. In fact, about 40% of psychiatrists are out of network with all insurances because it just does not pay well. A lot of states don't have parity for mental health treatment. Insurances, Medicare, Medicaids do not pay adequately to be able to make a private practice insurance-based self-sufficient, unfortunately.
When you have a patient reaching out to your practice and they ask you, do you take this insurance? How do you reply to that?
Sorry, but no.
Simple.
And once again, one of the ways that people find me, one of the main ways at this point, I would say like 80% of the time, the way that people find me or get to me is through my website. And my website, I am very clear about all the information. In big red letters going, I am out of network with all insurances. And so I do make it very clear that I am out of network. And so, if somebody contacts me, it's because they haven't checked my website. And so, I will let them know I'm out of network. Nope.
So you don't have to have a spiel about why you don't take insurance.
No. And the thing is, the majority of patients that I contact with, they get it because most of the I'm not usually the first psychiatrist that they're reaching out to. They've tried to going through their insurance or if they're Medicare, they've tried looking through Medicare network lists. They know it's extremely difficult to find a private practice psychiatrist, outpatient psychiatrist who is in network. And the ones that are on the network lists, there's usually like a 5, 6, 7, 8 month wait list.
I see. And now that you know about direct specialty care and about our Facebook group, did that help you in any way?
I definitely enjoy your group and seeing all that it has to offer, but I was already pretty busy by then.
That's good, and we do appreciate the fact that you took the time to spend with us, and the valuable advice that you give to people that are looking right now to get into direct care, or they are in the early stages of direct care. I know probably many of the people here, they just started or they are just considering to go into direct care. What is your advice from your perspective as an established psychiatrist at this point towards these people that are considering right now direct care?
Don't be afraid. Fear is probably the most difficult thing for all of us because we were not taught business skills in training. We were not taught medical legal skills. It's frightening, the idea of walking away from a stable paycheck to explore this whole new world where you're on your own and hoping it works and afraid that it will fail. It can be done. It absolutely can be done. Our colleagues have done it. There's a lot of very successful private specialty practices out there across all the different specialties. Including surgery, where you actually need a whole operating room to work. It is still possible. Know what you want, be very clear, and just go for it.
Do you think more physicians will come into direct care in the next, let's say, 5 years?
Considering how many physicians I have been treating for burnout and depression recently, I think so.
And do you recommend them to go? Because
I do. I encourage.
You do recommend them to go?
I always remind them that it is an option. Obviously, it takes a lot of work. A lot of people think, oh, if I started my own private practice, I can work less. I don't have to work quite as hard. I'll have more time for my family. In a way, that's true because you do have control over how many hours you want to work in your schedule. But when you are running a business, you are it. You are in charge of all the logistics, the accounting, the making sure that, legal stuff is taken care of, insurance stuff, answering all the calls. Okay, you are on 24/7 unless you find somebody else to partner with you for coverage. And you have to market. And marketing is what I do pretty much, constantly in my free time. My kid will tell you, I am always on my phone scrolling through Facebook. But you have much more blurring of your work-life balance. Okay, it's inevitable because you are on all the time, and the buck stops with you with your practice. So I actually work much harder. I work much longer hours. Not necessarily seeing patients work, but all the other stuff I have to take care of for my practice than I ever did for a clock in, clock out 9 to 5 job. But it's so fulfilling. It is absolutely worth it.
That's what I wanted to say. Is it fulfilling? It
I am
is.
a better doctor now than I ever was when I was getting a paycheck from somebody, because I am proud of how I can practice, and I get to pick the patients that work best for me. I'm not forced to see anybody that I don't feel like is a good fit. And it makes for a fantastic therapeutic relationship between me and my patients. And I've never been so happy to be a doctor, honestly.
Thank you so much for saying all of these words. They are so powerful and so true for all the people that were in direct care for a while, and I can confirm that. So now we're going to take some questions from people that are here. So if you would like to unmute yourself, whoever wants to ask questions, you're welcome to ask Dr. Chen questions. She's happy to be here and to answer your questions.
I have a question.
Yay! Martina, welcome and congratulations. So Martina recently opened her practice, direct care practice.
Well, actually, I announced it, but I'm only starting remodeling next week, so I'm not operational. But yeah, it was so good. So thank you both, Dr. Girnita and Dr. Cheng, for doing this, because it's so good to hear that it's not going to be easier, but it's going to be more satisfying. That's why I'm doing it. It's good to anticipate all the troubles, right? Or all the hurdles. So my questions are actually two. First one was, how did you decide on maybe three. How did you decide on your electronic medical record? And then number two, if they do ask you for a receipt, how do you so that the patients go to their insurances for reimbursement? Do you provide that, or how is that done? And third one, you said you don't deal with insurances. As a rheumatologist, I will have to. I think not. I will be direct. I will be hybrid, but I will have to deal with insurance as part of prior authorization. So, do you deal with that at all, or no?
Okay, so first question was, how did I pick an EMR, right?
Yeah.
Okay. So I started investigating telemedicine a long time ago, way before most other people got into it, way before it became mainstream. And at the time, unlike what happened after COVID started, there were very limited numbers of EMR platforms that were available. I got very lucky on hindsight that I got started early, because when I was starting to look into it, and this was while I was still doing some locums work, the big companies that were out doing telehealth were like Teladoc, MD Live, and American Well. Those are kind of the three big ones that were doing it at the time. American Well, in their bid to try to kind of claim more market share in the telemedicine space, was they tried to rope in and make it kind of like a one-stop shop for all the patients. They had general medicine, urgent care type of services to start with, ear infections, URI, stuff like that. But they decided, well, if we can also provide specialty care on our platform, that puts us one step ahead of Telecare and MD Live at the time. But they didn't want to have to pay for specialists. And so what they did was, we have this platform that we're using for EMR. Let's go ahead and offer it up for free to specialists out there who wants to do some telemedicine. And that way, even though we don't have to pay them, they will still be on our platform. And then we can at least, even if they're billing the patient separately and we're not getting any of that money, it at least, is a way to bring in more patients, because we could get to keep them on the platform. Okay. And so that was where I found them. They had their platform for use for free for private practice specialist practitioners back then. And I signed on. And since then, I've been grandfathered into the free program. So I don't pay anything for my EMR. I will say it sucks. It's a terrible EMR. It's very dated. It is clunky. There's a lot of features that it is missing, but it's free and hard to argue with a free platform. So I have not navigated myself off of it. I've just stayed on it, made it work. I work around the little quirks, but that's what I got. Unfortunately, it is no longer free. They are actually charging $200 a month for it. I do not recommend it. It is not worth $200 a month. So stay away from it.
Okay. That helps to know. I'm considering 2 other ones you haven't mentioned yet, but it's good to know. How about the super you provide?
So part of that EMR on Amwell, they rebranded under Amwell, so that's what they're called at this point. The platform automatically generates a downloadable super bill after all the visits, and so it takes care of that.
Okay, and I'm so embarrassed to say I forgot my third question, so I'm gonna let somebody else go.
Oh, prior authorizations, I think.
Yes.
Yeah, like for medications, whether you deal with that at all.
I generally don't. I let my patients know that because I don't deal with any of their insurance, if I have to fill out prior authorization paperwork, they have to schedule a separate visit specifically for me to do the paperwork, because I'm not going to waste my time trying to fill out paperwork and getting on the phone and stuff like that. The vast majority of the time, because, with my niche, I'm perinatal psych. I don't really use newer medications very often because newer medications don't have pregnancy safety data, okay, as robust as the older medications. So I primarily use a lot of the older generic medications that are pretty cheap anyway. And so there's very rarely a prior authorization issue with insurance. The times occasionally when there is, then I actually tell my patients about like GoodRx. It's like, hey, let's just bypass insurance because you can get this med actually cheaper than your copay if you do GoodRx. Or, since Mark Cuban's mail order pharmacy came out, that's been a godsend for me. I have been convincing a lot of my patients to just get it there. It's like, hey, they deliver it straight to your house. You don't even have to go to the pharmacy anymore. And their prices are dirt cheap. So I get around it that way.
Thank you so much. I appreciate it.
You're welcome.
Dr. Levy.
Hi, Dr. Levy. So I am a drug specialty care psychiatrist, so it's great to hear from you. I was looking at your website. You don't have a membership option right now, do you? And because I'm using a traditional, membership-based service, and those are some of my questions are about that. If you did that, and then also as part of the direct package, I also do like text, let my patients to text me and stuff. It goes right to the EMR. I'm running it like a true direct specialty care. Do you have anything like that for patients, like an email or anything like that, or a text number that patients can text you at or anything like that?
No, I decided not to go with the membership option because, to be perfectly honest, I'm very agent cheap. And I know for my own, just with my own personality, I hate paying membership fees. And so I decided that, and also, because of my niche, the way that my practice works is actually a lot of the times, the pregnant patients or the postpartum patients or patients who, are trying to conceive, they need a preconception consultation. I do one-time consultations for a big portion of my patients where I review all their medications for them. I write up recommendations for how to manage those medications. And then they take that and they take it back to their OB or, their previous psychiatrists who aren't comfortable dealing with perinatal stuff to kind of get them set up and then they can keep going. And I actually prefer to do it that way because I want to keep my practice open. I take pride in saying, I can get a new patient in within 2 weeks. And the only way to do that is by keeping open a rolling census. I don't want to keep patients long-term because when I take on a patient, they come to me most of the time pregnant and freaking out. So I hold them during the pregnancy and then up to the first 6 months postpartum, because once you get past that first 6 months, if you've been doing pretty well, your risk for developing postpartum stuff really, really goes down. I send them back. I'm like, you don't need me anymore. You're just taking this med. I'm only refilling once every 3 months going forward. Your OB can do that. Your primary can do that. Go back. And then I can take on more pregnant patients because there's always going to be women getting pregnant. And so the membership thing really isn't compatible with the niche that I'm in. I'm sorry, what was your second question?
Oh, yeah, that was part of it too, because I'm just going back and forth if I want to stay with the membership model. It's been good. I mean, I specialize in ADHD, and actually I do prescribe controlled substances by telemedicine. My approach is going to be, I mean, I don't think I can be multi-state, except that the new laws do allow for a referral from a specialist. So
If they pass, they are still proposed laws right now.
Correct. Yeah. And so anyways, for me, because I do a lot of like rapid titration of stimulants, the membership works for that. But then, the problem is once patients do well, I don't need to see them that frequent. And it doesn't become, I agree about being value conscious. The other part was about like, as part of being I talk about direct access to me through phones.
Text, right. Email. I don't, because that would drive me crazy. What I tell, because my patients are not paying for handholding. They pay for the visit, and that's it, and they know that. I tell my patients that I don't accept texts, I don't accept phones, I don't accept emails outside the EMR system. Now, the EMR system has a secure messaging system. If they want to reach me outside of visits, I tell them they can go and message me on that platform anytime. Okay, I get a phone notification when a message comes in. I'm actually pretty responsive about returning those, but I isolate those messages to the platform only. So I'm not getting random texts from weird numbers that I don't know coming in the middle of the night. I'm not getting emails that I have to be, responding through, and my Outlook is, filling up. I tell them you have to keep it on the platform. But I do make it a policy to be very quickly responsive because it reassures them. And when the patient is reassured that, they can reach their doctor and their doctor is going to respond, they become much more respectful of your time. So really, in practice, I have never had a patient reach out to me at 3 a.m. going, I'm having a crisis, I really need to hear. I've never had a patient do that. You're muted. I can't hear you.
You're muted.
No, I was just saying thank you. I am curious how I'm still on my own. I'm earlier than you in the journey, so trying to figure it all out.
Do what works for you. Your specialty niche and mine are very different, and my system works great for my type of patients. You need to find what works for your patients.
Great. For those people that do not know about the DEA regulations, can you tell us a little bit about that?
That's the other thing that I'm well known for. I'm the medical legal specialist on a lot of the Facebook groups, and I do a lot of webinars and education on that. So for anybody who does telemedicine needs to know Ryan Haidt. And Ryan Haidt Act, that was the federal law that limits the prescribing of controlled substance prescriptions via telehealth unless you have seen the patient in person at least once, ever. Okay, that got suspended during COVID for the COVID public health emergency. It became a bit of a free-for-all. You didn't have to have a DEA in every single state you were prescribing in. You didn't have to see the patient in person. And unfortunately, we had some bad actors that happened during COVID. They're under DEA and DOJ investigation at this point, but it did bring to light a lot of this rampant prescribing going on. And so when a few months ago, the administration announced the official end of the COVID public health emergency, that also means that the Ryan Haidt Act waivers would end, which means it is expected to come back in full again, starting May 12th of this year. Now, about end of February, the DEA did announce that they were considering a set of proposed rules that would extend some flexibilities for telehealth prescribing without the in-person requirement. And they posted that on their website. They opened it up for 30 days to public comment. They, one of the things they added was, a qualifying referral from another DEA registered physician. Also like a primary care doctor or pediatrician, et cetera, who has seen the patient in person and then refers the patient to a telehealth prescriber for controlled medication prescribing, even though the telehealth doctor has never seen the patient. There's a whole set of very stringent documentation criteria that are involved in that, but it does make that possible. So it does make it a little bit more flexible. But once again, those rules are proposals. And the public health comment period has ended. That ended at the end of March. We do not know when the finalized rules are coming out, and we do not know what shape or form those will come out in. They may look exactly like the proposed rules. They may look very different from the proposed rules. They may not come out at all because the DEA did not promise a deadline by which they were going to publish finalized rules. And so all the major professional associations, for me, American Psychiatric Association, they are telling, all their members, be prepared for Ryan Hyde Act coming back in force, full force, starting May 12th, with no grace period. Okay. Part of the proposed rules was they give a 6-month grace period for people who are, have been prescribing over COVID. The Ryan Hyde Act, if it comes back in full on May 12th, there is no grace period unless the DEA finalizes some rules. A lot of people misunderstood the proposed rules to be, this is what they're doing. We don't know yet. So don't make the mistake of thinking, oh yeah, we're good to go. We've got 6 months grace period. We don't know that yet.
Mm-hmm. Yes, and that is becoming more challenging for patients and also for physicians, but especially for patients that they do need someone to take over the controlled substance medication. And unfortunately, there is a lot of limitation in the pain management practices.
Well, and in psychiatry, child adolescent psych, they prescribe stimulants. That's bread and butter.
Yes.
A lot of other fields are affected as well. We can hope that, the DEA will come out with something reasonable at the end. But, the thing of concern with the DEA is they have not had a good history and track record of doing what people expect them to do. They were ordered by presidential decree, an executive order back in 2018 to come out with a special telemedicine registration system by October 2019. And we're in 2023 and it never came out because they just decided not to do it. And then when they came out and published the proposed rules, they actually specifically said, yeah, we decided not to do that after all. Mm-hmm. So they just threw out that whole order. So we don't know. During their public comment period, they received over 30,000 public comments. So who knows how long it's going to take for them to plow through all that to come up with a decision. And the thing is, the majority of those comments were highly critical of the proposals that they laid out. So we really don't know where they're going to land.
I see. Anybody else with questions? No? So if there are no more questions.
I would have, if I may, I don't know whether I'm allowed to have more than one go.
Chris, go ahead.
You are allowed.
Thank you. So because I'm still in the early phases, as I said, I'm actually meeting the banker. I'm closing on a loan today, and the remodeling is starting on Monday. So I don't have my website. What is your, if you can recall still from when you started, what is your, what would you recommend as a sequence? Do I do marketing first, or I guess the website would make most sense, right? Finish my website, update that, decide on the prices, then marketing, then hire some, I would like to have a medical assistant or a virtual assistant because I'm still working my regular job, my per diem job as I'm transitioning into my private practice because to basically support myself. So I'll be starting day and a half in my practice and 3.5 days in my regular job. So that was my question, the sequence of things of how to proceed when basically in order to allow for smooth beginning once the remodeling is done.
Well, the most important thing is to make sure that you are legally in the clear. So make sure you get all the legal stuff taken care of. You've got your malpractice coverage that will start before you start seeing patients. Any permits that you need done, both federal, state, county, city, whatever, all the permitting stuff is taken care of. Depending on what you're calling your private practice, if you're using a fictitious name, make sure that you get that registered properly.
Yeah, I have it. Yes.
Yeah. So, all the legal stuff, make sure your T's are crossed, your I's are dotted. And then after that, there's absolutely no reason to not get your website up. Your website is your main marketing tool, really. It's your public face that is up 24/7, that can be visited by potential referees or patients at any time. You don't have to have everything ready on your website. It doesn't have to be perfect. Okay, just get it up there. Get it so that Google, their bots can start churning the SEOs and it can start getting into those digital algorithms. You can always modify it later, add more information later on if you want to, but get it up there. And even if it's like, practice opening soon, and you have no fees, no prices, no nothing, it's fine. Just get it up there, get a picture of yourself, a little blurb about your practice, and add to it later, but at least it's there.
And do you have recommendations for did you do your own, or did you?
I built my own. I taught myself HTML. So, and my website is based on the WordPress platform.
Martin, you can reach out to me. I can refer you to someone.
Thank you so much for your time. I really appreciate it.
Anytime.
Sure.
We have Mariel.
Hi, thank you so
Hi.
much. I was wondering what who you use for your HIPAA compliance, like what company?
So, interesting thing, because I am direct cash pay, I am not a HIPAA covered entity.
I don't think that's true.
Yes, it is. If you go to the government
100%
website,
true.
yeah, if you go to the government website, there's a little flow sheet that you can take yourself through. If you don't bill a third party for any payment for medical services, you are not a HIPAA covered entity.
So I'm only cash pay also, and I know what you're talking about, except they also list the exception of if you're I remember what you're talking about, but because I'm crazy anal, which I think you are too. I feel the the camaraderie, but I could swear that there's a listing of, regardless of whether you're billing a third party, if you fall into the category of someone who's whatever, like dealing with PHI, there was some caveat that made it sound like regardless, you're
if you are
it's
direct
still
cash pay, if the patient pays you directly and it doesn't go through a third party where you have to report that the patient saw you or whatever to get payment, you are not a HIPAA covered entity.
Okay, well, I'm definitely gonna. Is it possible to make the particular thing that reference like available in the chat or something so that I could relook at that? Because that's probably one of my biggest expenses is a HIPAA compliancy.
Yeah. And I mean, I try to maintain HIPAA compliance in things as much as possible because, if you're meeting HIPAA compliance standards, you will also meet most state patient privacy law standards. And so just for best practices, I do try to do that. But that means that I am not, privy to, or I'm not accountable to a lot of HIPAA training or, all the other stuff. So
Right.
I don't need to bother with that.
So I'm sorry, remind me again, what was the entity that had the official proof so that I could rethink?
I think it was either the Health or Human Services government website or it was the CMS website.
Okay.
So in your contract, you can discuss with your lawyer, but in your contract that you sign with the patient, you sign and the patient signs, you have to specify even that you will make your best efforts to remain, under this HIPAA compliancy. I mean, to basically respect the privacy of the patient.
I just put it in chat. That's the flow sheet.
Thank you. But
thank you so much.
Primarily, you have to disclose that to the patient. And if you use an electronic medical record system, like I use, all my conversations are done through that platform with the patients, which, I don't know if it's fully HIPAA compliant, but the system, the electronic medical record system, it is supposed to be HIPAA compliant.
So you also, is there anybody in this group who I guess was foolish like me and they didn't realize that they were exempt and I'm just curious if this is like everybody does that or.
So in my perspective, I also have that in the contract that I sign with the patient, that I'm going to do the best that I can to protect their privacy, but, I'm not HIPAA, or I'm not under the HIPAA compliance law. You can add that to your contracts.
But any vendors or any platforms that I use that, where any type of patient data is going to pass through, I still get the business associates agreement from them. Like for my EMR, I've got a BAA from them.
From the
if I'm
email.
doing like secure fax stuff with them, I get the BAA from that. If I'm, I have 2 backup systems for the televideo connection in case my EMR breaks down. I have BAAs from those. And so, I still get the BAA so that I am covered for HIPAA compliance. I just, for the things that would be too difficult or would be too expensive, I don't bother with those.
Thank you so much.
What is BAA? Business Associates Agreement.
Yes.
That is basically the agreement that you have with the vendor, where the vendor promises to be to act responsibly about how they hold, store, transmit any type of secure patient health information data. And so, if you have that BAA, that means that your vendor is promising you that they're going to be responsible about all the stuff that they have control over. So if they have a hack, they are responsible for it. You are not, because you have that BAA agreement, and you have to have the BAA for anything to count as HIPAA compliant.
Okay, so hi, this is Dominica. But when you're saying vendor, do you mean your EMR, your EHR?
Any type of software platform that you use, like Zoom being a good example. A lot of practices use Zoom. The free version of Zoom, even though the free versus the professional, the paid version, they use the exact same encryption. Like they don't turn on and off encryption algorithms depending on whether you're free or paid. But if you're free, they refuse to give you a BAA. If you're paid, they will give you a BAA. So if you've got the paid version, it's HIPAA compliant.
When you set up your email, you also have to ask for a BAA.
Yeah. And only the paid version of like Outlook or paid version of Google Business, they will give you a BAA, but if you use the free version, they won't.
Yes.
Wow. See, I already have all these things, and maybe I don't even know that I have I'm going to have to look into that.
Ask them.
I've been in private practice. Oh, sorry. What was that?
Ask them to see.
Yeah.
So any time when you start basically business with someone, you should ask for the BAA.
Okay.
And the BAA is a fairly standard form.
Sure.
And so actually, if you go onto the website for Microsoft or for Zoom or whatnot, and you just type in their search the BAA or HIPAA compliance, a lot of the companies actually just have it downloadable, and then you just fill it in with your practice name and save it, and that's it. You're all good.
Oh, okay, great. Thank you for that.
Couple things. First of all, to Martina's question about websites and stuff like that, I use Squarespace, and the reason why is because they also have access to their Google Workspace, and you can send a BAA with Workspace, which will handle your Gmail. So that way I covered when I answer things by Gmail. 2 birds, 1 stone. But then also to Muriel's point, even though if HIPAA doesn't apply, you're still covered with 21st Century Cures Act, which has to do with information blocking and making sure that you don't do anything to inhibit a patient from accessing the records. That applies to anybody using an EHR. I sit on a HIT committee, and that's not limited to cash or anything like that. So make sure you know the Cures Act stuff. But again, as long as you give your records to a patient in a timely manner. Yeah. And then the last thing that I was going to ask for Dr. Cheng is do you still have Medicaid and Medicare? I mean, do you still stay on panel with insurers and Medicaid and Medicare? Because I kind of want to supervise.
I opted out of Medicare years ago.
But that means you can supervise trainees or anything like that. Can you? I
do not do clinical training with the residents. I teach, I lecture. So I'm a lecturer. I don't do it because I am very far away from Loma Linda. I'm in Northern California, Silicon Valley. That's like 6 hours drive away from Loma Linda. I can't supervise clinical care because I'm not physically there. But I'm adjunct faculty because I do a lot of virtual lectures.
Yeah, I think about supervising NPs, but
I also don't supervise NPs.
What's that?
I don't supervise NPs.
Yeah, because you need to be on panel. But I'm kind of nervous if I did that. And can you theoretically stay on panel and do private direct specialty care on the side?
Are you talking about Medicare?
Yeah, Medicare, Medicaid. Well, for me being pediatric, Medicaid, or even private insurance. We can take it from one venue.
So with Medicare, no. Medicare, if you're in anywhere, you're in everywhere. And so if if you're on Medicare or you're not opted out of Medicare, you are not allowed to charge any Medicare patient privately. Okay, you have to bill Medicare. You can't even give them a super bill and say, go ahead and ask Medicare for reimbursement. You are not allowed to take money from Medicare patients, period, unless you're opted out. Medicaid is state dependent. And so every state's kind of got their different laws. Some Medicaid, state laws are you have to be enrolled in order to provide care, or you have to be opted out. Some is like, we don't care. So you really have to check your state's Medicare laws. Private insurances are kind of the same thing. You have to check the contracts that you sign. Some private insurances in their contract will say you are only considered in network at this specific practice site. And you are credentialed for that site, and you're not credentialed anywhere else. And if you see another patient anywhere else, we're not going to pay you, and you can't pretend that you're in network. Some insurances are the opposite. They're like, we're credentialing you as the provider, and you are considered an in-network provider no matter where you practice. And so if you're in that situation, you are not allowed to bill those patients privately in your private practice if you're in network with, somewhere else.
That sounds like direct care would be compatible with a paid supervising gig or something like that. Yeah.
I don't supervise, so I actually don't know.
We will take one more question because we are almost 1 hour into this webinar.
I actually have a patient in 2 minutes. So.
Okay, then we have to stop.
No, it's okay. One more question.
Okay, go ahead. Quickly. I think Onyx, you have a question?
Hi, yes. Yes, thanks for taking my question. And sorry, I had a commitment, so I joined late. But I just wanted to get your thoughts on how on how to get patients and marketing. Someone had actually said I should reach out to you for your thoughts on that because
she did answer this question. So we're gonna post this webinar online on the YouTube channel, and you can watch how she did marketing for her practice. Dr. Chen, thank you so much for your time. Thank you so much for your knowledge. We really appreciate your time and your efforts through the group that we have. And I hope that you're going to join us in the future again.
Thank you so much for having me. That was a great time. You guys take care, everybody.
Thank you.
Bye.
Thank you. Thank you, everyone, for coming.